to CornerStones Best of DDW and IBD 2021 for New Zealand. So I am very grateful for Jensen for supporting this now for, I think it's about the 8th year in New Zealand, and certainly I think it really helps distill the very best of DDW and IBD for what we do here in New Zealand. So for CornerStones, it starts off with about 90 slides that we get sent, and then Miles Sparrow, Susie Connor, and myself go through and reduce that to about half of the ones that we believe are most useful for Australia and New Zealand, and then I edit them a little bit more. So we'll just go through the first few slides. So for those of you who don't know about CornerStones, it's been going now for quite a number of years, and essentially what happens is 40 of us usually meet at DDW. Obviously that's been difficult the last 2 years because it has existed only in the ether of the virtual world. And we go through all of the abstracts in DDW that are presented there. We look at what's most clinically relevant, we argue about it, and then we put together the slide set that is presented to you today. This is how we've met in the last year. So on here, you'll see Akhilesh Swaminathan in the bottom sort of middle there, at the bottom of base camp. He was the New Zealand fellow, IBD fellow this year. You'll also see Vivek Thariyev, who's coming back to Christchurch in a month or two. He's very important now. He's at the Mayo Clinic, so he gets his name with a Mayo Clinic after it to show how important he is. But it's a great thing that we do. These are the faculty from different parts of the world, and the fellows, as I mentioned, Akhilesh, and we had 2 in Vivek, who was representing Christchurch and the Mayo Clinic. Okay, so moving on to the first slide. This was a review of patient perspectives and expectations after a diagnosis of IBD and how that changes through the course of a disease. So this looked at 52 studies that were published around the world and looked at a range of different things that patients were interested in understanding and what their expectations were at different phases of the disease. Not surprisingly, at the time of diagnosis, a greater need for knowledge was identified, which makes sense as patients are trying to learn more about what's going on. During active disease, so a more severe disease, patients wanted more information, not just about the disease, but also workplace disability, coping strategies, complications from therapy, etc. I think what that highlights for me is that it's not just about the symptoms for patients, it's also about the way that the disease affects them overall. And I think the other key features that came out of this abstract were that the patient's focus initially was mostly on symptom control. The physician's focus mostly on endoscopic healing. Clearly, we need patients to also understand our targets, which include endoscopic healing, but we also need to remember the other symptoms, not just the gut symptoms, but fatigue and other things that can have an effect as well. All right, so in the United States at the moment, there are more and more programs that are getting underway which are looking at interdisciplinary care of inflammatory bowel disease. So this is a study looking at the COMPASS IBD program, which includes an IBD specialist, a nutritionist, a behavioural health specialist, and a pharmacist. And in this study, they compared patients who were looked after by this group with standard of care at the same institution, who were controls. And they followed these patients out for a year and looked at a range of outcomes. And here we've got presented clinical remission, BMI, and emergency department hospitalisation rate. And what you can see here is that those patients who were looked after using the interdisciplinary care, the COMPASS IBD program, were more likely, although not statistically significantly so, to be in clinical remission, more likely to have a normal BMI. It has been said in this cornerstone so far by one of the other attendees that maybe that's because it was from the US and maybe their BMIs were high and became normal, but nonetheless they had more participants with a normal BMI, and also significantly fewer emergency department visits and hospitalizations. And I think what's important to me in this slide is that even though clinical remission was only slightly improved, there was a massive improvement in emergency room visits and hospitalizations, which suggests to me that the role of that behavioural health specialist, in particular at looking at the way that people cope and manage their disease, probably had a pretty big role in what was going on. An observation from New Zealand perspective is that firstly, there's no IBD nurse in this team. which of course would be very difficult for us to contemplate here in New Zealand, although I've had an IBD nurse say that her role is one of an IBD specialist, a nutritionist, a behavioural health specialist, and a pharmacist anyway. So maybe in New Zealand we have more multi-talented people who can fill those roles. But I do think the role of this behavioural health specialist in particular probably had a pretty significant impact on what was going on. Okay, so this slide looks at workplace productivity loss and activity impairment in IBD patients, in addition to those with psoriasis and psoriatic arthritis. What you can see is here a cohort of 500 odd UC patients, 600 Crohn's patients, 4,700 psoriasis patients, and 1,200 psoriatic arthritis patients. And what you can see is 3 different domains here. So any absenteeism, any workplace productivity loss, any activity impairment, and then you can see how active the disease is in remission, mild and moderate. And what you can see here is that even with mild disease, patients with IBD were having on average more symptoms, particularly those with Crohn's disease, and more workplace productivity losses. And again, as you go across, certainly the IBD patients, their impairment's at least as great, if not greater, than those with the psoriatic arthritis. And I think these sort of data are useful to enable us to compare between diseases. It would be great if FRACP looked at these sort of data, because obviously that would be useful to make sure that they fund diseases where there is large impairment in our patients. But of course, FRACP don't look at indirect costs. But I think it is useful for me to see the impact of the disease on workplace productivity for our IBD patients. All right, so this is a study looking at the risk of Alzheimer's disease in IBD patients. This is from the Explorers database, and this database is enormous. It looks at 26 major US health systems and combines all the data. And it's run out of Cleveland, and Miguel Regueiro's group presented this data at DDW. To put this in context, there were 323,000 IBD patients who were enrolled on this database, so it's enormous. The benefit of this, of course, is the fantastic power that it gives you. The difficulty is you probably don't get the granularity of data to enable you to really understand what's going on. They then looked at the patients with IBD who also subsequently developed Alzheimer's disease and found 2,400 of those patients. When they looked at the risk factors for developing Alzheimer's disease in patients with IBD, they found that that was greatest with an increasing age, as one might expect. There was a slight increased risk with ulcerative colitis, but a greater increased risk or association with Crohn's disease. Also an increased risk with alcohol abuse and hypertension. And I suppose for me, when I look at this, I think about inflammaging, which is, as we get older, the increasing inflammatory burden that aging can place on our body. And if you have an inflammatory disease, that may be greater, and certainly that may be what's driving that. Alternatively, patients, of course, with Crohn's disease and ulcerative colitis may be more likely to have been smokers at some point, be it current smokers or ex-smokers, and that may, of course, increase vascular disease, which could be interpreted as Alzheimer's disease in some databases. But I think what it says to us is that there is this increased risk, and probably a lot of that will be around inflammation. They did look at anti-TNF biologic use and found that it was if you had that in Crohn's disease, your risk of Alzheimer's disease was decreased compared to others in the population, suggesting that inflammation may have been a role in that. It's important to know that there was a large population-based cohort study that looked at the same association published in Gut in January of this year, which showed the same thing. So again, suggesting that inflammation with IBD having this risk of developing Alzheimer's disease and other complications over time. Okay, so I'm just going to stop there if anyone's got any questions on any of those studies before we go on to the next section. As I mentioned earlier, if you want to talk amongst yourselves in the chat about the observations and the slides, feel free to do so. If they're in the questions, I'll stop and talk to them as well as we go. All right, no news is good news, or perhaps no one can hear me and have gone to sleep. Okay. So this study here is, this slide here is a combination of 3 different studies. that are all looking at the risk of developing inflammatory bowel disease following the intake of processed foods or ultra-processed foods. So processed foods are foods that are altered during preparation, including the addition of preservatives. Ultra-processed foods don't even really sound like foods. They're made from substrates extracted from foods and with additives such as those listed there, all being added to it as well. So number one on the left is the first of these studies looking at processed and ultra-processed foods. It's a large observational cohort study of over 100,000 participants from 21 countries looking at habitual food intake using a country-specific food frequency questionnaire. And then they looked at the people who developed inflammatory bowel disease in this cohort and looked back at what their intake of processed foods were. So on the bottom of those three arrows, you can see the baseline, which is less than 1 serving per day, with the baseline risk being unity of 1. And then as you increase the number of the servings of processed foods, you can see an increase in the risk, particularly of Crohn's disease, less so for ulcerative colitis. So these are reasonably high quality, prospectively collected data. It is a food frequency questionnaire, which has some issues around it, but nonetheless, this is consistent with what we're seeing in some other studies. The next study, number 2, that you can see on the slide is a combination of a large number of cohort studies. So the Nurses Health Study, the Nurses Health Study 2, and the Health Professionals Follow-Up Study. So in the study, they had over 5 million years of person years of follow-up. And what they found was that ultra-processed grain foods and fats and sauces increased the risk of Crohn's disease, no effect on ulcerative colitis. Interestingly, ready to heat and eat mixed dishes reduced the risk. Unclear why that was, but nonetheless, I'm suggesting here that high consumption of ultra-high processed grains, fats and sauces, emulsifiers, thickeners, all associated with an increased risk of Crohn's disease. So a bit of a consistent message coming through here. And the third study here on the right, number 3, is the weakest of the three. It's a small case control observational study. So it's retrospective. Patients have to, and controls have to describe what they ate early in life, and then they look at the risk of disease following that. I think this is a weak study because I'm not sure what I had for dinner last night, let alone what I had when I was a child. So I think there are going to be significant biases in these data. But again, it is a relatively consistent message coming through here as well. Okay, so this slide is from a study called the DINE-CD study. It's already been published this year in Gastroenterology. It's a rather unusual study which compares in a randomized controlled method the specific carbohydrate diet and a Mediterranean diet. And they're comparing those at looking at achievement of clinical remission rates in a randomized controlled trial. So just going through the data on the left, the methods, patients with mild to moderate symptoms of Crohn's disease were randomized to either the specific carbohydrate diet or the Mediterranean diet for 6 weeks. And the food was provided to the participants. So it's a reasonably big organizational feat to achieve that. Primary outcome, which was a Crohn's disease activity index of less than 150, was at 6 weeks. Then the participants continued out to 12 weeks where they provided their own food. So looking at this overall, looking at perhaps the graph on the far right, you can see that the rates of symptomatic remission between the two groups, blue being the Mediterranean diet and orange the specific carbohydrate diet, were the same for both symptomatic remission and clinical remission. You'll see that almost a third of participants had an improvement in their fecal calprotectin, although very few had an improvement in their CRP. If you look across here at signs of objective inflammation, what you can see here is that really very little in the way of change there. When we look at the changes in CDAI, or the baseline, the changes in CDAI, although it was statistically significant, that's not clinically significant in any way. So what this is suggesting is that both of these diets, compared to their baseline, have an effect. The big issue with this study was there was no control group. There was just two groups of two different diets that were compared against each other. So all we can say is that one group and the other were sort of similar, but we don't know what would have happened if they had no intervention whatsoever. So interesting study. Again, what it would suggest is that there is a effect on symptoms with regards to these outcomes and fecal calprotectin, but again, these are non-controlled studies. All right, so a couple of slides on obesity now, just to go through. So the first one is looking at the risk of Crohn's disease in patients with obesity. So this is from, again, this group of multiple cohort studies with over 600,000 participants, looking at all sorts of things all around the world. And what we can see, over 10 million person years of follow-up, 563 cases of CD, 1,000 cases of ulcerative colitis. We can see here that the risk of Crohn's disease, according to BMI at baseline, is certainly greater in Crohn's disease, both in univariate and in adjusted analysis. Furthermore, Crohn's disease later in life, according to early adulthood BMI, is also increased, again suggesting that there may be an association between a raised BMI of greater than 30 in this example and an increased risk of getting Crohn's disease, although not ulcerative colitis. And I suppose the question here is around fat potentially as an inflammatory organ in its own right, or other related factors with that, which we can talk about in a minute. This slide here combines two studies that both looked at visceral adipose tissue and visceral fat index and tried to look at whether those things predicted response and lower rates of remission in IBD. So these are studies looking prospectively in the first study, in the Constellation study, that steroid-free disease remission at week 14 is defined by a Harvey-Bradshaw index in normal CRP and Calpro off steroids. And what they did is they compared the outcomes in patients receiving biologics and rates of remission. And in particular, in the bottom of the two graphs there, you can see going across to the right, lower, and then as we go across to the right, higher VAT percentages. And then you can see remission defined in a variety of ways on the bars on the graph. And what you can see here is that the remission rates are significantly higher if you have a lower VAT percent, suggesting that that VAT in its own right may be a predictor of treatment response. And certainly there was discussion at DDW this year as to whether we should be looking at visceral adipose tissue percent or visceral fat index as a potential predictor of whether patients might respond to therapy, or even what sort of dose someone would be best to receive at baseline. Certainly from my point of view, I don't look so much at visceral adipose fat, but I suppose I do think about the very large patients and thinking whether a weight-based dosing regime for those patients, if I am using a biologic, would just seem more appropriate to me. But again, it's about understanding those data in the context of what's going on. All right, so here we're looking at dermatological manifestations in an IBD cohort of over 4,000 patients from Pittsburgh. And what they did is they tried to understand if you had one of these dermatological manifestations of inflammatory bowel disease, were you more or less likely to respond to therapy, and also did you have more aggressive or less aggressive disease? So looking first at 313 patients who have dermatological manifestations, you can see firstly that about a third of these patients have eczema, about a quarter have psoriasis, 22% pyoderma, and then the rest hidradenitis and bullous pemphigus, etc. I suppose my first observation on that is that a third of patients with eczema seems, I think, relatively low. I think mild eczema is very common, so this makes me think that these patients had maybe significant eczema. Also, it's unclear from this study what proportion of patients with psoriasis had this as a complication of biologic therapy, or how many had it as a de novo, as a independent disease that they developed themselves. So looking at this though, looking down the table on the right, what you can see is that patients with dermatological manifestations were significantly more likely to require more aggressive therapy, and were also significantly more likely to have a range of laboratory abnormalities that were consistent with active disease. So again, what it's suggesting here in my mind is that dermatological manifestations of inflammatory bowel disease are associated with increased rates of more aggressive disease. And I suppose, is it something that we need to look out for in our patients as they're diagnosed? I'm just seeing there's a question from Cameron. I might just have a look at. Can you give more details on the carbohydrate diet? What does it contain and what's excluded? Just before I go back, the specific carbohydrate diet, I don't have the details on it, but from what I understand, it's very popular on the east coast of the United States, according to Catherine Wall, who's a local IBD dietitian, and a lot of patients end up on it over there. There's less data on that than there are on other diets that we have in this space, but I can't give you the detail. It may have some of that in the abstract, which will be included with the handout, Cameron, that goes out, or else you could look it up. Perhaps you can look it up online. So just moving on to the next slide here. So this is from Cedars-Sinai, and they've identified a unique group of patients who they describe as UC to CD. And what this is a group of patients who were initially diagnosed as ulcerative colitis, but who subsequently go on to have their diagnosis changed to Crohn's disease. And of their population of about 6,000 patients that they have on their books, they identified this in 332 patients who had gone on from one thing to another. So these patients, when they went back and looked at them, they were more likely to be smokers, which one might expect given that they ended up having Crohn's disease. They were much more likely to have extraintestinal manifestations of both Crohn's and UC. And finally, they were also more likely to be primary non-responders to anti-TNF alpha therapies, with quite an impressive odds ratio there. I think for me, there are some flaws in this study. The first is that, in my experience, if you're someone who has ulcerative colitis and then goes on to develop Crohn's disease, often something pretty significant's happened to make that diagnosis occur. For example, it might be a patient who has had a colectomy for ulcerative colitis, has a pouch, and then their pouch fails because of profound fistulizing disease or stenosing disease. So by definition, those patients tend to be much more severe as far as I can imagine. So I think that suggests why this sort of more severe phenotype might be the case. However, they did go and do serological markers in these patients because they've got an interest in serology at Cedars-Sinai. And what you can see is the concentration of or levels of these various serological markers in red for UC, in blue for Crohn's disease, and green is the UC to CD cohort, and that's falling somewhere in between. So it perhaps is an interesting group, but I think in my experience, by definition, these patients are often very sick and have had a rough road to arrive at that diagnosis of Crohn's disease. Okay, so this study is from Adelaide in Australia, looking at the risk of going on to develop advanced neoplasia in a surveillance program of patients undergoing surveillance for colorectal cancer with inflammatory bowel disease. So what they found looking at almost 600 patients with IBD was that having a non-advanced adenoma at your baseline colonoscopy increased your risk significantly of going on to have an advanced neoplasia some point later in the disease. And the same was the case for those who had an advanced adenoma at baseline, also more likely to go on and have that advanced neoplasia subsequently. Age was also a risk factor, as one might imagine. The older people were, the more likely this was to be an issue. But interestingly, when it came to medication use, there was a significant increase in advanced neoplasias in patients who were having long-term prednisone use, as opposed to those who were not, suggesting that prednisone use was associated with an increased risk of this. But of course, the question is, why might that be? The way I would interpret this, I think, is that the patients on long-term prednisone are an unusual group. I think they may be more likely to have very refractory disease, perhaps. They may be potentially less likely to see a gastroenterologist regularly, because most gastroenterologists will be trying hard to get them off prednisone and onto a disease-modifying therapy. So it may well be that this marker of prednisone use is more a marker of chronicity of disease, of potentially of age, and also of amount and degree of inflammation that's present. But I think just another reason to try and minimise our prednisone use, I suppose. But to me, it speaks more about controlling inflammation, treating to target, and getting that inflammation under control. All right, so this study isn't quite so clinically relevant, but it's just fascinating. We've included it, even though, as I say, it's not necessarily going to change your practice right now. So it's in New York. The group at Mount Sinai have gone into the Jewish Ashkenazi population there, who often don't mix a lot with other people. They tend to be a reasonably insular community, but they've got very high rates of Crohn's disease and inflammatory bowel disease. And they've recruited multiplex families with multiple family members and unaffected family members together, and they're following these people prospectively. So they've done gene studies, they've looked at environmental risk factors, they've looked at microbiome. So very similar to the GEM study, which a number of us may have contributed here in New Zealand, being run out of Canada. And what they've done in this, they had a number of slides at DDW, but in this study, what they're showing is the microbiome patterns that you might see over time in these people. So OTU type 2 is a low diversity dysbiosis state, and most IBD patients have this type of microbiome. What they've done is they've looked at this in these families, and what they found was that unaffected first-degree relatives of people with IBD will often develop an IBD-associated microbiome with dysbiosis in adolescence. So you can see this sort of in the graph on the far bottom right, where you can see this increase in this OTU type 2 dysbiosis occurring after adolescence. I think why this is interesting to me is that obviously we know that the peak ages of incidence for inflammatory bowel disease are between late adolescence and probably 40 or so. And what we're seeing here is potentially a dysbiosis that may be occurring before that diagnosis is made. Now, we won't know that until we have decades of follow-up in this cohort. But I think the fact that we're seeing a change in microbiome before potential disease in a group of patients, a group of the population who have a very high risk of getting inflammatory bowel disease, I think is fascinating, and to me potentially promises sort of that pre-diagnosis screening thing that we may be interested in, and what you can see now for type 1 diabetes with their serological testing, for example. So again, isn't going to change your practice right now, but probably just provides a bit more data to suggest that the microbiome may be important either in its own right, or might be something that's modified that's associated with the risk that subsequently comes. So interesting, even if not changing your practice today. All right, I'll just stop there at that point to see if there's any other questions from that section. Any comments? As I mentioned before, please feel free to chat in the chat or not, and ask questions through the question area, and I'll stop and answer them intermittently. All right, so I'm just going to move on to the next section. So often in CornerStones, I don't spend large amounts of time talking about drugs that we don't have. And the reason is I feel like it's torture. Just because Pharmac won't fund the drugs that we really need in IBD in New Zealand makes it hard for us to listen to all these new drugs that are on their way or being made available in other parts of the world. However, this year I thought it was slightly different because there are a number of drugs now that are either have just been approved for IBD in the States, or are on their way to being approved, or are available in clinical trials in New Zealand. So I just wanted to give a bit of an overview of what's coming, and although I accept we don't necessarily have access to them now, maybe someday in the future we will. So this slide here is quite helpful for really giving an idea about treatment options for moderate to severe IBD that we have now and that are coming in the future. So we all know about steroids, thiopurines, and methotrexate. The anti-integrins, natalizumab and vedolizumab, we don't have in New Zealand, but of course is another class of drug that would be that we'd love to have. The anti-P40 is an anti-IL-23 drug, ustekinumab or Stelara, that most of you will know about, and is used extensively overseas and most non-third world countries except New Zealand. Anti-TNF alphas you will have heard of, Adalimumab and andfliximab are the two we have in New Zealand. We have the JAK inhibitors, or Janus kinase inhibitors. Now, these are oral small molecule drugs. There are three targets, three different types of inhibitors, and tofacitinib is a pan-JAK inhibitor, so it inhibits all of those. There's S1P receptor modulators, or Ozanimod, which is now available in the US, approved by the FDA in June of this year for ulcerative colitis. Then on to the next slide, we have some other IL-23 drugs, but these are P19 unit specific, and I'll talk about that in a little while. We've got other JAK inhibitors that are selective, such as filgotinib, apetitinib. I can't pronounce any of these names, I'm sorry. And then there's some other drugs that are on their way that are coming. So I'm going to go through some of these today, and hopefully that overview gives you a bit of an understanding about where these drugs sit on the spectrum and where they may be coming and fit in. So this slide is really combining 4 different studies. I'm not going to go through the details of these significantly, but just to tell you that tofacitinib, which is now available in most places in the world for ulcerative colitis, showing that in the real-world studies of these patients being given these drugs, the safety and efficacy endpoints are similar to what's happening in the controlled trials. So the real world is living up to what we're seeing in the controlled trials, which is good. With this drug, we worry a bit about Zoster. So you can see there 3% Zoster infection, and also thromboembolic events at the higher doses, but they weren't super high. Now, filgotinib is a Janus kinase inhibitor, but it's a selective Janus kinase inhibitor, only looking at Janus kinase, the third type. And what you can see here is that in this phase 2b/3 study, that this drug appears to be efficacious. So effective, well tolerated in ulcerative colitis. So again, I think this will be a drug that we'll be seeing more of soon. And the safety signals appear to be good so far. All right, so I'm just going to talk a little bit about the S1P modulators, just because they're a new class of drug that you may not have heard about before. There was a study here, the Receptos study in New Zealand, quite a while ago that included ozanimod. So some of us may have used it in that study. Well, the drug is now available for ulcerative colitis in the US, as mentioned. So what these drugs do is they block egress of lymphocytes from lymphoid tissue into the tissue. So you can see on the diagram there, they're stopping these lymphocytes, effector T cells, for example, from migrating out of the lymphocytes and lymphoid tissue into the intestine. And by doing that, obviously reduce inflammation. So that's the mechanism. And I think what's wonderful is we are getting more and more new mechanisms all the time, which hopefully will mean we've got more options for our IBD patients. So here are the efficacy data at week 10. So for induction of remission, intention to treat data, clinical remission in about just under 20%. So but response in 50%, endoscopic improvement in just over a quarter, and mucosal healing in a small proportion. This is at 10 weeks for a small molecule, which I suppose is okay, but we might expect better. If we look at how quickly this happens, and again, I'm not going to go through each slide, each part of the slide, but just to give you the overview, what you can see is that rectal bleeding improved significantly within 2 weeks. And looking at the calprotectin change there, you can see significant reductions in fecal calprotectin compared to baseline, and also compared to placebo. So significant changes in objective markers of gut inflammation, including calprotectin and CRP. So here are the week 52 data now, so maintenance. What you can see here, clinical remission in about 40% of participants, response in about 60%, endoscopic improvement and remission in reasonable amounts. So these data are good data. They're showing efficacy symptomatically and also mucosal healing in a proportion, not in everyone, but certainly significant improvements over time. So another new drug for ulcerative colitis, and I think that's a useful thing. As with many of these small molecules, though, they don't come without their range of side effects. So for ozanimod, it can affect your heart. You have to keep an eye on your eyes, liver, blood count. It feels almost a bit like a new azathioprine, but with a different range of side effects in some ways. So again, we'll learn more about these things over time, and maybe by the time it's available in New Zealand, we'll know all about them completely. All right, so going from the new drugs now, briefly dipping out of those and looking at some old drugs. Here are some data on tacrolimus being used topically, and it's a systematic review looking at observational studies of tacrolimus use in proctitis, perianal Crohn's disease, chronic pouchitis, all put together on one graph. So 11 studies, 188 participants in all, so not huge numbers. These are all uncontrolled data. So we're seeing reasonable rates of remission and response in proctitis and perianal Crohn's and in refractory pouchitis. I'm not aware of large numbers of people using this in New Zealand. I think you'd have to get tacrolimus made up, especially by your pharmacist, into an enema. You could potentially add it to an existing enema formulation, I suppose, but again, these are untested, unproven in randomized trials, but I suppose for your patients with nothing else to offer could potentially be helpful. So I think it's something to think about for patients with these distal diseases. I think Tony Smith said he used a tacrolimus paste in someone with bad perianal fistula and had a positive response from that a long time ago. All right, so I'll just stop there. Any other questions on that group of slides, just while I pause for a moment? Okay, I'll move on. All right, so I think this for me was one of the most important studies at DDW this year. So I'll just take a little bit of time going through it. It's very similar to the story study. The story study, you'll remember, is an infliximab stopping study that looked at randomizing patients to stopping or continuing infliximab. To me, this study is good because it reflects the sort of patients who I might think about having a discussion about stopping infliximab in. So these are patients who have clinical, biochemical, and endoscopic remission. So they are completely well. And these patients were randomized to either continuation of infliximab or placebo. So it's a prospective randomized placebo-controlled trial. They're allowed to continue their immunosuppression, and the primary endpoint was time to relapse, which was looking at clinical relapse using a CDAI over time. And patients on infliximab for perianal disease were excluded. Now, when I first looked at this Kaplan-Meier curve, I thought, gosh, all those lines look about the same there, but what I was missing was the solid black line across the top. So what that black line there is they're the participants who remained on infliximab over that 1 year period. And in that group, 100% of them remained in remission over that time, as opposed to those patients who stopped infliximab and were on placebo, in which 50% of those people relapsed over time. So you had a 50% chance, flip a coin, of having a clinical relapse over that time. If you look at the combined endpoint of clinical and endoscopic remission at 48 weeks, you can see that, again, infliximab was far superior to placebo. Concomitant immunosuppression increased the time to relapse, but it was still significantly shorter in those who continue infliximab. So I think this study is useful for me. I think it's a similar message to story. And what I would now say to my patients who want to stop infliximab is that if they are in complete remission, clinical, biochemical, and endoscopic, and they stop their infliximab, they've got a 50-50 chance of having a clinical relapse within a year, and an even greater chance of having a clinical or endoscopic remission within a year. So, people should be free to make their choices, but they just have to understand what that means. Interestingly, last year at DDW, they presented 7 or 8 year follow-up from the story study. And what they said in that follow-up was that these patients had ended up, many of them had been able to have their biologic restarted, and a proportion of those had been successful, but not in everyone. Some of those patients didn't need their biologic restarted. Some had their biologic restarted, but they needed to go on to a second or third biologic because the infliximab didn't work. So I think we need to just consider how all that fits in together. Just a couple of questions coming in here. I'll just stop because I think they're all about this. So, question from Hui, will this infliximab discontinued trial also carry on to study recapturing response? So, great question. Those data weren't reported here. What I would say is there was another study from DDW last year or the year before where they looked at that question. So in patients who were stopping infliximab, they followed them prospectively in people who did and did not continue their immunomodulator. And certainly, if I was in a situation where I was stopping infliximab, I would definitely want the patient to continue with an immunomodulator, because in that study, the rates of lack of ability to recapture response or an adverse event when the biologic was reintroduced were very high. So I think I'd be very concerned about about stopping infliximab or adalimumab and not having an immunomodulator in its place, especially in New Zealand, where if you lose response to one of these drugs, you're in big trouble because you just don't have any other agents that are there. Sean says any data on length of remission prior to stopping. So I'd have to look at the author block. Let me just double check. They'd been treated with standard maintenance therapy for at least a year in complete remission. So it doesn't say that in the abstract, Sean. So only what's on here and in the abstract. So it doesn't say how long their disease duration was for, but clearly that's going to be important. Again, Hui says, I wonder if this response is, if it's recaptured, if it's sustained. So in the follow-up from the story study, which I think has been published now at 7 years, I think that certainly for a proportion, I think there are about 20 or 30% of people who were on no drug and they would continue to be fine. But I think there was a sort of 10 to 20% who had done badly. So they hadn't been able to maintain response, recapture response, sustain response, or recapture response with a new drug. So I think it's a difficult one, and clearly there's no one right answer for everyone, but I think these data are useful because you can say to a patient who wants to stop, well, let's scope you, get some blood tests, look at your symptoms. If it's all normal, I can tell you you've got a 50% chance of being okay at the end of the year. And what I find is that the patients who want to stop are typically the patients who've got a bad memory of how bad their disease was. The patients who want to continue with the drug tend to be those who've got a very good memory of how sick they were and never want to go back there again. But I think these are really useful data. All right, so biosimilars have arrived worldwide. We're lucky because we have Uncle Pharmac to make all decisions about drug choice for us. But in other parts of the world, there are often switches within hospitals and multiple switches. So here we can see a prospective study from Edinburgh, and they've looked at drug persistence, biochemical clinical remission after elective switches from one biosimilar to another, and from then one biosimilar from Remicade to a biosimilar to another biosimilar. The one thing I would say about the new biosimilars, they've got the most fantastic names. So Zesli and Ziffy, I think it is. They just sound great. But anyway, that's probably by the by. The key findings from the study was there was no major differences that occurred in clinical or biochemical remission at baseline in week 26 in the single or double switch. So they're suggesting that certainly single and multiple biosimilar infliximab switches appear safe, and they couldn't see in their cohort of 229 patients any significant negative effects in clinical outcomes. So an observational study, but prospectively done anyway. Just as there is a biosimilar, there are biosimilars for infliximab, there are biosimilars for adalimumab now. Imraldi is the one that is available, or SB5. These are retrospective observational data from a single centre looking at an elective switch to Imraldi and seeing what happened. And what they found was there wasn't any significant change that they could see in treatment efficacy and safety out to a year. So again, these drugs are around. We need to know about them, but I imagine that Uncle Pharmac will make these decisions for us. But I suppose it's useful that if we were in a situation where we had to move to a biosimilar, that the data that are coming out in real world studies anyway appear to be reassuring. All right, so this is the ultimate in torture for New Zealanders, because this is a long way from ever happening in real world. So this is looking at patients who have, with ulcerative colitis, who have failed both an anti-TNF and an anti-integrin and vedolizumab, now trying to decide, should we give the patients tofacitinib or ustekinumab? So again, we're a long way away from this, but these studies are now being done. It is a retrospective cohort study though, so there'll be biases in the way that people are included in one of these treatment groups or the other. But nonetheless, they did a propensity score weighting analysis to try and understand, was there a difference between the two drugs? It looks as though overall, certainly from a treatment and stereofree remission rate, there wasn't a significant difference between the two drugs. There's a signal of maybe some higher rates of ADRs or infections in the tofa group, but it wasn't statistically significant. So again, suggesting in this study, albeit retrospective and single centre from one unit, that there wasn't a difference between these two drugs in this group of patients who had failed two different agents, two of these agents already. This is a similar study looking at ustekinumab and vedolizumab and achieving steroid-free remission in Crohn's disease patients who are refractory to anti-TNF therapy. So I suppose the drugs we're most likely to get in New Zealand, if we overly like to get other ones, would be ustekinumab and maybe vedolizumab. So this could be a question that we are given at some point as to which of these two drugs would we prefer to use. Again, these data are retrospective. It's a multi-center study. Again, propensity matched analysis, so they sort of make up numbers to compare the two groups, which there are some issues with. And the primary endpoint was steroid-free remission at week 54, but other endpoints were earlier and included calprotectin, etc. On the graph on the right, what you can see is that the rates of remission or steroid-free remission at week 10 were significantly higher in ustekinumab than vedolizumab. However, the data on vedolizumab do suggest a slower onset of action, and certainly that might be what you would expect potentially over time. So in some subgroups of patients, again, ustekinumab appeared to be better than vedolizumab. So it's good to see that these sorts of studies are being done. These are retrospective though, and I think we just need to take them with a grain of salt for now. All right, so this study is from Rupert Leung's group in Australia. What they were doing was looking at the PBS data to determine which drug, whether vedolizumab or an anti-TNF alpha, if used as first line, which one had the longest persistence. So how long do patients remain on drug over time? And persistence is a marker of both efficacy, because for someone to remain on the drug, it's got to keep working, and also tolerability and absence of side effects. So it's a reasonable surrogate. So what they found with the study is that patients using vedolizumab first line had longer persistence than andfliximab, and second line it was the other way around. The issue with the study though is that it is pharmaceutical data. It'd be like going to the special authorities in New Zealand and trying to understand what's happening from those. And we know that while in New Zealand we're very honest at doing the special authorities, and it's all clearly exactly by the book, we're not sure whether in Australia using the PBS, again, how robust those data are. However, there are many hundreds of patients in the study, so certainly the suggestion is that this may be an interesting result nonetheless. All right, so we're now moving into an era where there are actually some prospective head-to-head studies of drugs for inflammatory bowel disease. So this is a multi-center randomized double-blind parallel group active controlled study called SeaView, comparing ustekinumab and adalimumab for induction and maintenance of moderate to severe Crohn's disease. So patients are randomized 1-to-1 to ustekinumab or adalimumab, and the primary endpoint was clinical remission at week 52. So there are 386 patients in the study, and at week 52, 65% of those in the ustekinumab and 61% of those in the adalimumab group were in clinical remission, and there's no difference between the two. And that's shown on the graph on the right, showing the remission rates over time. On this slide are the secondary endpoints from the study, and you'll see that for most of the secondary endpoints, there was no significant difference between the two drugs, including steroid-free remission, clinical response rate, and endoscopic remission. There were some signs, though, for some of the endpoints, such as maintenance of clinical response at week 52 of those who responded earlier, that was greater in ustekinumab, and also for some of the steroid-free endpoints, and also for the changes in SES-CD, as you can see on the graph on the left there, did favour ustekinumab, but really there wasn't much in the study between those two agents. So interesting, yeah, hopefully we can get ustekinumab in the future in this head-to-head study, very similar efficacy. Again, I'd also say with this study, there's no dose optimization here, so we don't know, all these patients were given standard dosing of these drugs, which we know may not be enough for many of them. All right, so this isn't in the slide deck, but I just wanted to spend a little bit of time talking about IL-23, because IL-23 is a major target that's coming your way, and I think it's really important that you understand what's going on with it. So IL-23 is on the left there, and IL-12 is on the right. And you'll see that both IL-23 and the IL-12 receptor share the P40 subunit. So if you use a drug like ustekinumab or I'm terrible with these drug names, but I'll try, Briakinumab, they will block P40, which will mean that you'll get IL-23 blockade, but you'll also get IL-12 blockade. Some of the new IL-23 agents are P19 specific. So these include risankizumab, brazikumab, Gazelkameb, mirikizumab, and tacrolimus. I'm sorry, I'm terrible with this pronunciation. So all of a sudden here we've got different targets within a target, if you like. And I think it's just important looking forward as I go through some of these studies, especially for the P19 drugs, just to think about why this might be useful and also what this may mean for potentially our option for drugs going forward. Before I leave the slide, I will just mention secukinumab, which is now available for one of the rheumatological diseases. Of course, they get lots of options as we get no future ones. So here are some data looking at MIRI. It's a lot easier to say MIRI than the full name, in moderate to severe Crohn's disease. Again, it's a P19 drug. These are phase 2 studies. And essentially, I'm not going to go through the data in detail, but they show efficacy and safety, durable endoscopic and symptomatic efficacy in these patients. And certainly they're now in phase 3 studies in the VIVID trials looking at this drug. So risankizumab is a drug that has been available in New Zealand in clinical trials, and certainly we've contributed quite a few patients to the Crohn's trial, which is some of the data here, but also we have a trial in ulcerative colitis, which we are recruiting for as well at the moment. So here we can see the endoscopic response and remission in patients with moderate to severe Crohn's disease, significant benefits in both doses of the drug compared to placebo for clinical remission and endoscopic response as well. So certainly looking as though for induction of remission endoscopically, it's successful at doing that. Okay, Gazelkameb is another one of these P19 drugs, and these data here are from Crohn's disease phase 2 study. And here they're looking at biomarker and endoscopic improvement. And the really interesting thing about the Gazelkameb studies, from my point of view, is that not only do they have placebo, which you can see there in the grey on the far left of the two slides looking at endoscopic healing, they have a range of doses, but the purple one there is ustekinumab. So they have an active comparator in this study as well. So the patients have a chance of getting placebo, but a chance of getting the study drug, or ustekinumab, a drug that they can't get in New Zealand at the moment. So I think in Dunedin they're recruiting for the study. We're recruiting in Christchurch. We've got 1, maybe 2 patients. We're looking to put a lot of patients into the study just because they've got such a good chance of getting an IL-23 drug, which may be either a P19 subunit 1 or a P40 subunit 1. And I think that's really a fantastic option for patients. So we're looking to get a lot of patients into these studies. So if you've got patients in the South Island outside of the Dunedin area, we're happy to have them recruited and sent to us. And we're happy to do that. And I think other units in the country are also looking to get this study up and underway as well. All right, so this study here was a retrospective observational study looking at colitis and cancer outcomes from patients who had immune-mediated diarrhea or colitis from one of the checkpoint inhibitor drugs. So I can't say we've seen much of this in Canterbury as yet, but certainly overseas where a lot of these drugs are prescribed, diarrhea and colitis is a well-described side effect. And patients have been being treated with infliximab and now increasingly vedolizumab as well. And what these studies showed was that infliximab was faster at getting people well. There was certainly significant differences in hospitalization and recurrent IMDC for those having vedolizumab. But probably the key feature here was that vedolizumab being used for this indication was associated with a lower risk of cancer progression than those using infliximab. And that would sort of make sense because obviously with vedolizumab, you've got colon-specific immunosuppression. So you're not getting immunosuppression to other parts of the body where the cancer may be, whereas infliximab, that's obviously a more global immunosuppression, so there might be slightly higher rates. So certainly, if we were to have this, it would be good to have access to both of these drugs. I'm not sure they're indicated in New Zealand for either of them at the moment, but that would be certainly an option that could be available. All right, so again, this is just of interest rather than being strictly clinically relevant right now. This is a study of Adalimumab, which is an IL-6 blocker. Now, IL-6 has been a really interesting target in IBD, and there have been a number of studies done previously that have shown that IL-6 blockade is not effective. However, what they've done here is they've gone to IL-6 and looked at blockade of the trans IL-6 receptor rather than the cis receptor. And by doing that and developing a drug that can block that, they've got significant effects here at mucosal healing, clinical remission and response in this UC cohort. So I think what's interesting for me here is that just because a target doesn't work the first time you go at it, if you can go in another way, in a different way, you may be able to have a good outcome from those patients. So again, this is in phase 2. Phase 3 studies will be coming. All right, so this is one of my final slides that's going to really torture you. There's more slides to come, but this is the torture slide. So yeah, in New Zealand, we've got Adalimumab and infliximab. Overseas, they've got tofacitinib, vedolizumab, ustekinumab, natalizumab, and other drugs on their way. And here's a slide from a review looking at a range of studies that combine these biologics or small molecules together to see whether they are safe and efficacious. And essentially what they've suggested in this is that it's a really horrific combination of studies that have been done in different ways, very hard to combine them together. There seems to be pretty similar responses, though. They didn't describe any major adverse safety intervals. I can just see Pharmac having coronary artery disease events and seizures simultaneously, thinking about funding this sort of these sort of drug treatments. But I suppose what I'm just showing you is that this is the sort of thing that's happening overseas, increasingly in some parts of the world. All right, I'll just stop and get my breath here for a minute. Any questions on that group of slides or anything similar that I've been through so far? So as I said, I don't usually go through all the new drugs that are coming, but I think this year with so many new IL-23 drugs that are coming and so other small molecules, and with ozanimod also being funded or approved in the US, I think we are sort of at a point where there's a bit of a tipping point with the number of drugs that might be available to us and that are coming. All right, so looking at this slide, this is from the Pittsburgh group again, looking at routine things that you might see in histology or in biochemistry and determining can you use those in a model to predict whether someone will continue on infliximab or whether they may do worse. So this group's looked a lot at granulomas, at eosinophils, peripheral blood monocytosis, for example, and have shown in the past that all of those are associated with more severe disease trajectory in Crohn's disease. What they've done here is they've used a model to combine these, and by doing that and looking at the weighted composite score, they can see that it has an effect on infliximab discontinuation and other markers of healthcare utilization and clinical parameters. So for me, it's not so much that I'm going to use this model, but more that certainly when I look at blood counts now, I don't just look at the full blood, I don't just look at the hemoglobin and the platelets. I'm also looking at the eosinophils and monocytes just to get a feel for what else is going on. You know, these are easy things we can pick up, and all these biomarkers can be helpful. All right, so a couple of studies on COVID, because we're not out of the woods quite yet. So these are data from the Secure IBD initiative, which I was part of as well. I think the data have been helpful, but there are major issues with the data because it's a self-reported registry. So you only get into the registry if you came to a doctor's notice and that doctor decided to put you in. So clearly there are a number of biases that could occur in that process. This, I think, in some ways reflects that, because in the study what they showed was that those patients with more severe Crohn's disease or ulcerative colitis were more likely to have more severe COVID. But of course, what one would expect is that if you have more severe IBD, you're more likely to see your doctor, and you're more likely to get a COVID test, and you're more likely to have a severe outcome. So I think these things are highly confounded. But I think that that messaging around COVID vaccination that's on there is an important one. I think certainly we know that our patients who are immunosuppressed are in group 3 and should be being offered vaccination right now. I think it's important as clinicians to be strongly supportive of that to ensure that our patients get vaccinated in a timely manner. This study from the US doesn't tell us anything new, but it tells us what we did know in a much more robust way, if you like. So this is from Kaiser Permanente. It's a large insurer in the US. And the great thing about this study is that they've got a defined population. So they know exactly what's going on with all the people in this population, how many have got IBD, how many have got COVID, and then they can look at use of different drugs to determine what the risk of adverse outcomes from COVID, such as hospitalization, ICU, or death, were. And what they found was the same signal as we've found with in other studies, which is that being on prednisone is associated with an increased risk of those poor adverse outcomes from COVID. So again, the signal wasn't as strong as we saw in some of the other studies, but it's still consistent, and again in a defined population, which I think is really useful. All right, so this study was from Exeter, and what they did is they used blood spots to use in order to do biologic TDM and also to look at antibody measures as well. So what they did is they asked patients to send a finger prick blood spot in, and then use that in order to using an ELISA, and compared that to conventional venipuncture. And obviously, in a COVID world where perhaps you don't want everyone coming into hospital all the time for blood tests, this sort of thing obviously makes a lot of sense. And what they found was that in general, the biologic sampling and anti-drug antibodies were comparable and equivalent, and the patients preferred having the blood spots to anything else. So certainly that's useful. So a question from Jan. Big shout out to Jan, because Jan's in managed isolation at the moment, I think. And I imagine knowing Jan, he'd be absolutely loving that, because he's the sort of guy who likes just sitting around inside not doing very much. So full credit to you, Jan. We're looking forward to having you back in Christchurch. So Jan's asked about the association between 5-ASA and more severe COVID. So from the first cut of the secure IBD data, this association of 5-ASA use and worse outcome came out. And I was on the conference calls because I'm an author on that paper as we discussed that. And on that call, we had a lot of other people who have got very large IBD brains trying to understand what that meant. And certainly we didn't understand it. We're not sure we believed it. We crunched the numbers every way we possibly could, but the result was real. So we published it, but with a lot of caveats around it. In the next cut of the data, and I think there's about 6,000 IBD COVID patients in the database now, that is no longer an association. So I think it's no longer significant. So I think it was a red herring. It's one of those things that can come up statistically. It may be been a feature of the reporting somehow, but it hasn't been maintained out in that study nor in any other study that's been done subsequently. So certainly we would not be advocating that patients stop 5-ASA. In fact, if they do that, they're likely to end up on steroids. So definitely not stopping 5-ASA. Okay. This is another study, I think, which was was probably my second favourite study from DDW, and it's a post hoc analysis, which I hate, but I don't mind it because it was sort of a post hoc analysis that wasn't involved so much in the drugs that were being tested, but more around what you might do to predict disease outcomes subsequently. So this is using data from the Varsity trial. So the Varsity trial we presented last year at CornerStones. It was presented at DDW, and it was comparing vedolizumab to adalimumab for the treatment of ulcerative colitis. And what they did is they went back to the data from that study, and they looked at the week 14 calprotectin, and then they looked at mucosal healing at the week 14 colonoscopies, and then they looked at how well the calprotectin or the mucosal healing predicted the outcomes listed on the left of that graph. So clinical remission, endoscopic improvement, endoscopic remission, histological remission. And what you can see there is that the fecal calprotectin odds ratios are very comparable to the mucosal healing ones that are described below there as well. And to me, that really backs up the data that's come out of STRIDE 2, which are the sort of new treat to target studies that are suggesting that in the first instance, we were very interested in everyone getting scoped to be sure that they were responding, but now suggesting that we've got good data in this and in CALM to suggest that calprotectin can be used in that way. So again, I think that's really useful as well. So I'll just stop there because Cameron's asked a question, COVID vaccination can be given during an IBD flare-up, ? So and as far as I'm concerned, patients should just get it as soon as they can. I know there's been debate amongst the rheumatologists about when to give it if patients are on a biologic in that cycle, whether you give it at trough or at peak or when that should be. As far as I'm concerned, from the data that we're seeing coming out of studies such as the Clarity study from the UK, it appears that they're not seeing any significant signal with regards to what's going on with regards to drug use. So I therefore would probably, I would probably, if you can wait, you could wait, but I'd be happy just to get on and give the vaccination as soon as I can. The key thing from that Clarity study, of course, was that the rates of seroconversion after one dose of vaccine was significantly less than the general population, but after two, it was just as high. So again, I think Cameron and I would probably give I would give the vaccine. I think the key is just getting people vaccinated as soon as we're able to. All right, so this is an interesting new way for pathologists to describe IBD. And the reason that this consensus conference came about was that there are some already histological indices for inflammatory bowel disease, such as the Nancy index and the simplified Gabot score, but they're really difficult to use, and there's a lot of inter-individual variability in the reporting. So they've tried to take a reductionist approach and come up with a very simple score for assessing IBD histology, and it's called the DCA. And all you do is score distribution, chronicity, and activity. And what they're now trying to do is to try and correlate this with the Nancy and the Gabot index, and also trying to see how well it's accepted amongst pathologists and clinicians. So I think the benefit is potentially it's reproducible, it's easy to look at. So I think if there are any registrars out there looking for a project to do, I think this would be a great project. If you found a friendly pathologist and started looking at some samples just to see, can you use this to predict, and how good is inter-rater agreement, because this study was done in people who were all experts, but it would be good to know in other groups how well it was done. All right, I think we're getting close to the end. Just a few more studies to go through. So we'll move on now. So the study looked at paternal exposure to immunosuppression and then subsequent congenital malformations, preterm births or low birth weights in the progeny. So they used a data warehouse using de-identified data looking at a range of inflammatory conditions, most of which had inflammatory bowel disease, looking at fathers who are on immunosuppressants, including methotrexate, thiopurines, and anti-TNF drugs, and then looked at the outcomes of congenital malformations, preterm birth, and low birth weight. They also linked maternally, linked to the mothers to see whether any maternal factors could predispose to any of those outcomes as well. And what they found was that the rates were similar between the two groups, really, between those who were exposed and weren't exposed. The one issue with the study is that the only way you could get into the study was to have a live birth. So therefore, it didn't assess infertility, abortion, or stillbirth, but nonetheless, it still did have relatively large numbers of patients, fathers who are exposed to a range of drugs that are often given in this situation. So I think that's still useful and certainly reassuring from my point of view. Okay, so it couldn't be CornerStones without having some data from the Piano Registry. So the Piano Registry is a prospective study where data were collected through pregnancy for women with IBD and then following pregnancy into the postpartum years to look at outcomes with regards to drugs and other agents. So what they did here was they looked back specifically at steroid use, and what they found was that steroid use in pregnancy was associated with a significant increase of low birth weight, preterm birth, and NICU stay. in first trimester exposure was associated with a significant increased risk of congenital malformations in the the infant. So certainly significant suggestions there of issues. And I suppose this is a difficult one, because if you have an IBD patient who's flaring, are you going to start them on a biologic if they weren't already on one? Giving steroids is quite easy, but this study would suggest that that does increase the risk of some worse birth outcomes for babies. So I think interesting, I think we need to work out how we deal with the mother with active disease in pregnancy. It is a difficult one. In this study, there were five newborns with exposure to steroids with a cleft lip or palate versus one without exposure. So that was one of the major findings, and certainly cleft palate has been associated with early steroid use in the past, and that was the driver of that congenital malformation group. All right, so this is not a great graph. My apologies for that. This is just a very sort of rough study, if you like. Two centres retrospectively looking at all their patients who had a resection, and then looking at the disease recurrence in those prescribed no biologic and anti-TNF, ustekinumab or vedolizumab. It's retrospective, so clearly patients weren't randomised onto any of those agents, so there'll be biases involved in how people were selected, but it was propensity matched to try and get around that. And they defined recurrence endoscopically and radiologically. And what they could see there was that once you would do all the adjustments, there weren't any major differences between the drugs. There was a suggestion that ustekinumab approached significance but didn't quite make it. So interesting, but suggesting no significant difference between these drugs for disease recurrence, and also showing high disease recurrence rates endoscopically and radiologically, which is what we'd expect in this Crohn's disease group. All right, so this study is again from this Explorers database that I spoke about at the start of the presentation, which is this enormous US database. So here, 31 million individuals in the database, 250,000 IBD patients. They looked at also those with biologics. They then looked at the prevalence of osteoporosis in these patients, and also the prevalence of bone fractures. And what they found was that if you were treated with a biologic, you're less likely to have osteoporosis and you're less likely to have a bone fracture. Now, clearly there'll be significant biases involved here. The patients might have been on a biologic. Well, some might have had access to biologics, some may not have. There might have been different rituals in steroid use, you may think, but it did appear that the steroid exposure was similar between the two groups of those who used and those who did not use biologics. So it would appear from this very large study that biologic use reduced the risk of osteoporosis and bone fracture, and that may be related to disease activity and that sort of that inflammatory effect outside of the gut. All right, and I think this is my last data slide. So this is a slide again, a database, readmissions database looked at for patients who had inflammatory bowel disease, Crohn's or UC, with or without NAFLD, and propensity matching for a range of different factors, and looking at IBD readmissions or death, length of stay, additional costs of care. What they found was that if you had IBD and NAFLD, you're more likely to be readmitted, more likely to have a longer length of stay, higher costs of care, and things were generally worse. And I suppose that's not surprising in that if you have two problems, you're probably more likely to have an issue than if you have just one problem with regards to these outcomes. So perhaps not super surprising, but interesting nonetheless. So that's the end of the data slides for tonight. Happy to take any more questions or have chat in the chat. I suppose the new and notable things from this year for me were some new drugs. Adalimumab has arrived in the US. All these new P19 inhibitors, which are on their way, and many of which are available in clinical trials in New Zealand. So look out for where that might be available for your patients if they don't have other options, or even if you want to give them a trial option instead of a standard option. I think the head-to-head data of ustekinumab and adalimumab for Crohn's disease are interesting, in that now we are doing these studies prospectively, and I think we need more of them. And certainly Vedo appeared to be a better first-line drug than second-line in UC. The TOFA and ustekinumab safety data were as expected, and no new disease associations with diet. So new disease associations with diet, processed foods and ultra-processed foods in IBD, and Alzheimer's disease as a potential complication of Crohn's disease, and less so sort of colitis. So thank you for joining tonight. Thank you for Joanna for organising this and with CornerStones. Thank you for Jansen for supporting it.